On January 15, 2026, former and potential future President Donald Trump unveiled a new healthcare vision called the Great Healthcare Plan. With a simple slogan, "We want to get costs down, way down," the plan promises a fundamental re-architecture of how Americans pay for medical care, shifting power from insurers to individuals. But beyond the headlines, this isn't just a political platform. It's a proposed experiment in health economics and human behavior. If implemented, it would touch every American patient, doctor, and hospital. But what would this plan actually do? How would it work compared to the current system? And what does its reliance on transparency and health savings accounts tell us about a deeper underlying diagnosis of what's broken in American healthcare? Welcome to Health Inside, Anatomy and Science. Today, we're performing a nonpartisan anatomical dissection of the Great Healthcare Plan. We'll trace the flow of money under this new proposal, analyze the potential biological and financial impacts on patients with chronic diseases, and decode the high-stakes gamble at its core. Can unleashing the power of consumer shopping fix a system driven by sickness, not health? Part 1. The core principle, from third-party payer to patient as payer. Voice. To understand the plan, you must understand the current system's default setting. In most employer-based and ACA marketplace plans, you pay a premium, and your insurance company acts as a powerful, opaque intermediary. They negotiate prices with hospitals and drug companies, often in secret. You, the patient, are largely insulated from the true cost until you get a bill for your deductible or copay. Trump's plan aims to flip this model. Its central mechanism is sending federal money directly to individuals, likely through expanded health savings accounts, HSAs. The theory is simple. If you're spending your own HSA money on an MRI, you'll shop for the best price. This competition, the theory goes, will force providers to publish and lower their prices. This is a direct repudiation of the Affordable Care Act's subsidy model, where the government pays insurers to lower premiums for qualified individuals. That model expired at the end of 2025, creating a policy vacuum this plan seeks to fill. Part 2. The Four Pillars, a policy breakdown. Voice. The framework rests on four main proposals. Let's examine the science and economics behind each. 1. Direct payments and HSAs, the new financial engine. Proposal. Replace insurer subsidies with direct payments to individuals for purchasing insurance and care. Potential upside. Could increase a sense of ownership and incentivize price shopping for routine, shoppable services, e.g. blood tests, basic imaging. Critical unknowns and risks. The single most important detail is the payment amount. If the direct payment is less than the current ACA subsidy, millions could see their net insurance costs rise. This model also poses a severe risk for older and sicker individuals. A person with diabetes or cancer doesn't have the luxury of shopping for the cheapest oncologist or endocrinologist. They need specific, often expensive specialists. A flat payment may not cover their needs, effectively penalizing them for being sick. 2. Most favored nation drug pricing, attacking pharma. Proposal. Legally tie U.S. drug prices to the lowest prices paid in other developed countries like Canada or the UK. The science of drug development. This is the most populist and technically complex part. The pharmaceutical industry argues high U.S. prices fund the risky research and development for global breakthroughs. Imposing foreign price controls, they claim, would stifle innovation for future cures. Proponents argue other countries' free ride on U.S. innovation and that prices are artificially inflated by middlemen like PBMs. Potential impact could dramatically lower list prices for seniors on Medicare and potentially for all Americans, but could face fierce legal and legislative challenges. 3. Radical price transparency, the information cure. Proposal. Force all providers who accept federal money, Medicare, Medicaid, to publicly post all prices and fees. Force insurers to publish plain English data on profits and claims denials. The diagnosis. This directly targets the asymmetric information problem. The patient has no idea what anything costs until after they get it. True transparency could empower shopping. The complication: healthcare is not a simple commodity. In an emergency, you can't shop. For complex care, the price is a bundle of surgeon, facility, anesthesia, and pathology fees that are nearly impossible to bundle pre-service. 4. Ending PBM kickbacks, the middleman target. Proposal: eliminate hidden rebates and fees paid by drug makers to pharmacy benefit managers like CVS Carmack, Optum Rx, and Express Scripts. The biology of the PBM. PBMs are the shadowy negotiators between drug makers and insurers. They often take a percentage of a drug's list price as a rebate. Critics say this system incentivizes PBMs to favor high list price drugs, which yield bigger rebates, over truly cheaper alternatives, keeping overall costs high. Impact: this could simplify the drug supply chain and align incentives, but dismantling a multi-billion-dollar industry practice would be a monumental fight. Part 3. The Patient Impact Analysis: Chronic Disease versus the Healthy Consumer. Voice: the plan creates two potential patient archetypes with very different outcomes. The healthy consumer, a young, healthy individual needing only occasional checkups and generic drugs. Under this model, with a robust HSA, they could shop for cheap, transparent primary care and save money. The plan likely works for them. The chronic disease patient, an individual with diabetes, heart failure, or cancer. Their care is not shoppable. It's continuous, specialized, and expensive. A flat, direct payment may be quickly exhausted. If transparency reveals their specialist charges more, they have little choice but to pay or forego care. For them, the plan could create financial toxicity, the severe economic burden of treatment that worsens health outcomes. This is the plan's core tension. It's optimized for the economics of health, but American healthcare's costs are driven by the economics of sickness. Part 4. The Unknowns, the plan's shadow anatomy. Voice: the framework is notably silent on critical, system-defining details. Pre-existing conditions. Does it retain the ACA's popular guarantees that insurers cannot deny coverage or charge more based on health status? The framework doesn't specify. Medicaid and Medicare. How would it alter these massive foundational programs? It mentions using them as levers for transparency, but doesn't propose structural changes. The individual mandate. Would it bring back a penalty for being uninsured? The economic viability of insurance markets often relies on getting healthy people into the risk pool. Implementation and cost. There is no detailed legislative text, scoring from the Congressional Budget Office, or clear timeline. In a divided Congress, these details are the plan. Part 5. The Bigger Picture, what the debate reveals. Voice: the great healthcare plan debate, regardless of its fate, highlights the unresolved fundamental conflicts in American health policy. Universal coverage versus individual choice. Should the system guarantee care for all, or maximize freedom for individuals to choose and potentially forego insurance? Regulation versus market forces. Should government set prices and rules, or can transparent, consumer-driven markets discipline costs? Sick care versus health care. Are we funding a system that intervenes when people are sick, or should we incentivize and pay for prevention and wellness? This plan leans heavily into choice, markets, and individual responsibility. Its potential to lower costs for some is real, but its risk of raising costs and complexity for the most vulnerable is so real. As with any major medical intervention, the dosage and specific application matter more than the name of the drug. The coming debate will be about those specifics, the size of the checks, the protections for the sick, and the fine print that ultimately determines whether this prescription relieves the patient or worsens the condition. If this analytical breakdown of a major healthcare proposal helped you understand the high-stakes policy debate, please give this video a thumbs up. Informed citizens are the best check on any system. Share it to elevate the discussion beyond slogans. Subscribe to Health Inside, Anatomy and Science, and hit the bell. We analyze the systems that determine your health access, costs, and outcomes, from biology to bureaucracy. Stay informed, ask detailed questions, and follow the evidence.